Today we have a guest, and he told me the main introduction I should give is he's coming from Florence, and he's born in 1979, right? So this was the main introduction I should tell you. But besides that, I have to tell you some other things, that he actually graduated in 1979 in medicine, also in Florence, so most things are in Florence, OOS. And then he was into internal medicine in Florence, 1984. And then he went to the US quite a long time. He was at Duke, he was at UCLA, and he was at Case Western, where he now also has a joint professorship since last year. And then he returned actually to Florence, of course, which was in 1991. There he became assistant professor, and since 2000 he is now full professor. And additionally now he has his joint professorship in Case Western. I think Massimo Pinzani is one of the well-known people worldwide working in liver, and especially in fibrosis, and I think most of the people knows him. He was in gastro editor, associate editor, he was in hepatology, he was everywhere around, and I think everybody will like him, will know him, and we're very happy to have him here. Thank you very much for coming.
Thank you very much, Christian. It's a pleasure to be in Aachen and in this fantastic, like Alice in the Wonderland hospital. And I had to decide what to deliver today, and I could go into giving you like recent raw data, but then I thought that probably it was the case to come with a kind of a wise message. And what I believe is that hepatology, and particularly the area of liver fibrosis, is really at the age of a strong need to translate into clinical needs. Because I have been seeing Christian, for example, for many years, and also some of the younger guys, and we are excellent in basic science, and it's beautiful work. But then many of us, we are also physicians, and then we go back to work with the patients, and we realize that all this wealth that come from all this laboratory, and likely most of the laboratory within Europe, which is probably right now better than the US, as a community, that we don't have enough translation for the clinical needs. So first of all, I would like to introduce this talk on how research on fibrosis has changed clinical practice in hepatology. And this is very much reflected by this meeting, this EASL monothematic conference that will be held next year, January 28-29, that I am an organizer together with Laurent Castera, which is mostly a clinician. It doesn't have much basic science background, because we thought that probably although we are not going to talk about fibrosis, but we will show many topics where the interpretation of the disease has changed, and now the fibrotic evolution is key in the interpretation of how the disease progresses and how luckily the disease can regress if we can have appropriate therapies. So some points we will come up in this meeting. The difference between now and 20 years ago is that even people very much involved in viral hepatitis now, they just not talk about viral eradication. They also talk about fibrosis regression, which is a good thing to hear, because I think we have been very much frustrated in the time where we were putting lots of effort in fibrosis, and everybody was just talking about viral hepatitis, virus, biology, and interferon, and so on. Also, there is a growing introduction of non-invasive methods in association with liver biopsy, and I would like to stress in association with liver biopsy, not substituting liver biopsy. And here is where there is lots of space for translating basic information into clinical tools. And also, we know more and more that cirrhosis is not just the end stage of the disease, but is a new stage of the disease that may last 20 years, and we know very little about the biology of cirrhosis. We know a lot about the complication, but right now, if you want to classify a patient, we have only the Child-Pugh score or the MELD score, which are basically allocation systems for transplantation. That means that they are really end-stage tools. And also, let's say, the dream is that one day we should have a system where we can detect fibrosis progression, but also the decrease of liver function. And right now, there is no sensitive method to tell about very early changes in hepatocellular function. So 2010, all this work done on hepatic fibrosis. And what can we associate with this area? First of all, portal hypertension and hepatocellular carcinoma, these are two relevant issues, and it's very well recognized that the fibrotic evolution is responsible for portal hypertension, leading to the complication of the disease, and also somehow is responsible for the development of cancer. So these are two key clinical areas which have a very close interdependence with hepatic fibrosis. Then if we go to more clinical topics, there is this topic of the non-invasive evaluation of fibrosis, and also the issue of effective antifibrotic therapy. So I will try in my talk to have somehow an overview of this point. So you all know that the natural history of a chronic viral infection, for example, hepatitis C, we go from acute infection to chronic infection and to cirrhosis. And there are still lots of things to understand why 30% of patients have spontaneous resolution, why some patients have slow progression and some patients have fast progression. So there is lots to clarify yet, although, I mean, this is pretty clear, and nobody is surprised if a patient develops cirrhosis in less time than another. And it's pretty well known that alcohol, insulin resistance, obesity, immunodepression may accelerate the process. But this is just to make a point, in terms of needing to translate from basic to clinical, there are many aspects in this itinerary that needs to be clarified. And also, if we look at the progression of, I make the case of hepatitis C because it's the most common and the most investigated. So if you look at the progression of fibrosis in hepatitis C, and these are the two end-stage F3, F4 metavir, and this is the day of infection. These are years after infection. You see that it takes a long time before the average patient develops some significant fibrosis and cirrhosis. And this slope is quite flat for many years. At some point, many patients develop a faster progression. This is called the rapid phase of the fibrogenic evolution. Like there is something changing at some point after many years of disease. And we know that there are several factors that are relevant for how this slope is more or less flat. For example, I already mentioned obesity, alcohol, genetic factor, also the male sex and the age of infection are important. In general terms, when I try to explain to the students, why we get fibrosis, and the other question is fibrosis, tissue fibrosis, a good or a bad thing? Because this is an important point. Obviously, you'll think that it's a bad thing because it leads to a chronic disease and also to death. But somehow it's the best solution that let's say Mother Nature has organized for chronic damage. So if we have, in general, if we have like an epithelial injury, there are several steps: activation of coagulation, organization of inflammatory infiltrate, recruitment of fibrogenic cells, and then you have this community of fibrogenic cells that for many years for the liver was identified with stellate cell, is indeed a population made by different cell types. For example, there are several contributors beside stellate cell: resident liver myofibroblast, fibrocytes, which are cells coming from the bone marrow and differentiating in myofibroblasts in the liver. And there is some possibility about epithelial mesenchymal transition and also endothelial mesenchymal transition that I personally don't believe very much, but I have to put in the slide just for just because it's everywhere. And also at some point this repair gets more organized with some angiogenesis, and at some point this is like a mature scar, and if the damage is single, it goes in the direction of remodeling of this scar and tissue regeneration. If the injury is chronic, there will be a perpetuation of all these stages that will be together for a long time, and this leads to fibrotic healing. And there is lots of research now and lots of interest about the different populations, basically considering their origin, although as profibrogenic cells, they all behave basically the same way. I mean, they respond to the same growth factor and they all make matrix. And so if we want to make some biological and clinical implication, from what I show you now, it's very clear that fibrogenesis is part of a chronic wound healing reaction, and it is per se an intention to treat. Basically, without fibrosis, there will be probably just necrosis and inflammation, and there will be a parenchymal collapse. So likely the patient won't survive 40 years. Will likely survive less than 40 years. So per se, chronic wound healing is positive because keep the tissue together. And according to this first statement, if you ask me, would you treat, if you have a good antifibrotic drug, would you treat a patient just with the antifibrotic drug? And my answer would be, it would be probably very negative to treat fibrosis without removing the cause of damage. So if you want to treat first with antivirals and associate an antifibrotic, it's okay. But just the antifibrotic, at least until you become an established cirrhotic patient, would be probably negative. And just to describe how the history goes from the etiological agent to hepatocellular carcinoma, the common point between in all these causes like viral hepatitis, alcohol, metabolic or iron overload is basically a chronic tissue damage, chronic wound healing, fibrogenesis associated with angiogenesis, and this leads to a totally different microenvironment that in the liver, since there is an organ that is pushed to regenerate, is an ideal combination to get cancer. And indeed, if you wait enough, every patient with hepatocellular carcinoma will likely develop cancer. In biological, but also in clinical terms, not all fibrogenic disorders have the same pattern of fibrosis. For example, the biliary type of fibrosis has a quite peculiar biology because fibrosis tend to develop between portal tract, so the central lobular vein is involved only very late, and this is why most of cholestatic disorders don't have portal hypertension until very late stages. The vascular type is typical of the Budd-Chiari syndrome of chronic heart failure. It's a totally reversible fibrosis that goes between central lobular vein, and it's called inverted lobulation because the portal tracts tend to stay in the middle. Post-necrotic is typical of viral hepatitis or autoimmune hepatitis, and there is an involvement of the central lobular vein since very early stage. And then the ASH-NASH, which is typical of zone 3 and has this pericellular chicken wire pattern. And what, I'm not showing you this to you because I'm sure you know this, but just to stress that, when we talk about several fibrogenic populations, it's very clear that, according to where fibrosis starts, there is a population that is more responsible than the other. So, for example, in NASH, you will have probably pure stellate cell involvement in the beginning, but in chronic viral hepatitis, you will have probably more myofibroblasts from the portal tract becoming involved before stellate cells. And also, this is just to recapitulate all the population that can lead to myofibroblast. And I already put an interrogation mark on EMT. There were some enthusiastic papers, but now the new paper, especially from David Brenner's lab, where they use an appropriate methodology of fate tracking of the cells, they show that hepatocytes don't become myofibroblasts. So there is this little chapter, that has been built up in the last 5 years, will start to get, more unstable. And also, some lab have proposed something, that is a bit for us, old people in fibrosis, that stellate cell could be also a precursor, or stem cell for hepatocytes. And then, at this point, I think, when I read this paper, I thought that maybe I should retire because I'm not prepared for such a change. I mean, I think it's a bit too much. Okay. Then, okay, so let's see how we can work with these topics. So a very relevant point that link fibrogenesis with portal hypertension and cancer is angiogenesis. And our lab has been dedicated some attention in the past few years, and particularly angiogenesis related to portal hypertension more than angiogenesis related to cancer. So how does angiogenesis fit in chronic liver disease? There is angiogenesis, which is part of chronic wound healing. As I showed before, there is formation of new vessels. And indeed, when you have a scar on your skin, before you get a white scar, you get a red scar because it's full of vessels. So this is part of the wound healing process. And this leads to portal hypertension because you have resistance to portal flow because of changing of the hepatic architecture. This leads to splanchnic vasodilation, increased splanchnic oxidative stress, and hypoxia. And this leads to splanchnic neoangiogenesis. So there is another angiogenesis developing in the intestine, in the splanchnic circulation. And this aggravates portal hypertension because it increases the portal inflow. And then there is development of cancer, which develop its own new angiogenesis. So angiogenesis is very relevant in different stages of the disease, in the beginning, in the continuation of the disease, and also when the patient develops cancer. And just to give an example, there's a long time that the circulating level of VEGF, which is one of the most potent angiogenic factors, has been shown to increase from healthy subject to subject with chronic hepatitis and cirrhosis, and with the highest level in patients with HCC. And also, this author were also able to differentiate the stage of HCC according to the level of VEGF. I mean, this is a bit kind of superficial, naive kind of study, but just give an example how there is an increase of a circulating growth factor in this situation. And indeed, the endpoint of chronic liver disease is the development of cirrhosis, which is not just a lot of fibrosis. It's a totally different organ. And this is a cast of the matrix in the cirrhotic liver. And this is the cast of the vessels. Is a cast of the vessel in normal liver. So the main difference is that it's totally different. And you have, and then you have these big holes. And these holes where you have the cirrhotic nodules, so the residual hepatocytes are here. And these other holes is where you have the new vessels. And the new vessels basically connect directly the portal circulation with the hepatic vein circulation, like two trees. They are normally one over the other communicating with the leaves. In this case, they start communicating with the major branches. So shunting most of the hepatocellular function. And so why there is the development of new vessels, neoangiogenesis in chronic liver disease? Well, the first reason is because, as I said before already, this is part of the chronic wound healing response. So all these growth factors are available in the chronic wound healing, and many of these growth factors are pro-angiogenic. So on the long term, they will tend to make new vessels. And also because the main stimulus for angiogenesis is hypoxia, and there is indeed development of hypoxia in the progression of chronic liver disease. How this happen? Okay, first of all, a bit of physiology. In most tissue, hypoxia, the average pressure of oxygen is superior to 20 millimeters of mercury, and many organs, but not the liver, they start to think there is a hypoxic status when PO2 go before less than 10 millimeters of mercury. The liver has a different situation because it works with very little oxygen. So if you go from the portal tract to the central-lobular vein, the need for oxygen, decrease progressively, and you can have here level of 5 and 10, which in other organ will be regarded as hypoxia. So basically, the liver works with very little oxygen consumption. And indeed, the liver has normally a constitutive VEGF expression, around the central lobular vein, and also it has an activation of the HIF-1 alpha, which is a transcription factor promoting VEGF synthesis in the same area. So it's an organ with a basic close to hypoxia physiological status. And hypoxia, the presence of hypoxia activates transcription factor, particularly HIF-1 alpha, that leads to the synthesis of VEGF and angiogenesis. And why there is development of hypoxia with the progression of fibrosis? Okay, this is a portal lobule to portal tract. This is a type of fibrosis called portal to central, typical of chronic viral hepatitis, with septa connecting the portal tract, expansion of the portal tract, and septa connecting with the central lobular vein. And this is more like the NASH type, with fibrosis starting from the central lobular vein and then expanding to the portal tract. So in all this situation, there is a progressive increase of the role of the hepatic artery, which is very little, normally, and becomes very relevant, with the progression of the disease. So basically, the sinusoidal blood flow becomes progressively more and more oxygenated, and hepatocytes become spoiled. So they are used to have little oxygen, and they start working with lots of oxygen. So this is okay, until the moment that the position of matrix in the space of this, which is called capillarization of sinusoids, prevent the diffusion of oxygen. So basically, they become, adapted to high oxygen, and slowly they will have less and less oxygen. So at some point, they start developing, increasing transcription for VEGF. They feel hypoxic, and they will start producing more and more VEGF. Okay, indeed, this has been shown in different models. If you look here, this is a CCL4 model. This is a VEGF expression, and this is a marker of hypoxia pimonidazole. You have increased expression of VEGF and hypoxia going from normal liver to a cirrhotic liver. Same thing here in another paper. Here, in addition to VEGF, they show also increased expression of angiopoietin-1, which is another important vascular growth factor. And just to give you an example how we can translate these information. So we are in the process of doing this work. It's still unpublished. We are getting more and more cases using misonidazole, which is the equivalent for human as pimonidazole, the marker of hypoxia I showed you before. This can be used for PET scanning, can be given to the patient IV, and it works this way. Pimonidazole gets in all cells, and if it finds oxygen in the cell, gets degraded, so disappears. If there is a little oxygen, it accumulates in the cell and becomes a marker. And the data we have so far is that going from F0 fibrosis towards F4, there is a progressive increase of pimonidazole scanning, so you can detect hypoxia increasing quite sharply in the liver. And actually, the relevant thing we are seeing, and now we have, say, double data than this, that is very able to differentiate F2, which is a stage of significant fibrosis, which is a very important endpoint in the evaluation of progression. So, we should basically find all the possible technology and reproduce this, with, in humans, what we see in animals. Okay, then hypoxia is not the only stimulus for increasing VEGF. There is also what is called hypoxia-independent stabilization of the transcription factor HIF-1 alpha. And the two most relevant examples in chronic liver disease are, beside chronic inflammation, which is part of the wound healing process, is the effect of hepatitis C virus and leptin that may activate directly angiogenesis. This is an example of two papers that we have published over the years about the effect of viral proteins on hepatic stellate cell in terms of direct profibrogenic effect. For example, the HCV has a surface protein called E2 that interacts with CD81, which is a tetraspanin expressed on the surface of stellate cell. This activates PI4 kinase and the intracellular pathway that leads to increased synthesis of gelatinase, which is the metalloprotease that destroy the normal space of this extracellular matrix. This allows inflammatory cells and virus to get into the space of this. Also, more recently, we have shown that GP120, which is expressed on the HIV variant, interact with CCR5 and increase MCP1. So, I mean, if we consider like an ideal situation of co-infection, hepatitis C, HIV, you have also direct effect of viral protein promoting inflammation, degradation of matrix, and penetration of immune cells in contact with infected hepatocytes. Another relevant thing is that, okay, you know David, from Michelangelo, and is in Florence. But then if David, sits too much and eat too much and watch too much television, become like this, and his leptin will increase. And indeed, we have been working on adipokine effect on angiogenesis, and particularly leptin, which is significantly increased in overweight patient with a metabolic syndrome. So if you look at these are human hepatic stellate cell expression of RNA from angiopoietin 1 and VEGF. If you put the cell in hypoxic condition, you have upregulation of this RNA. But also, if you put the cells in normal oxygen condition with leptin, you have the same increase of VEGF and also activation of the protein and also activation of the transcription factor. So there are factors independent from hypoxia which are directly pro-angiogenic. And also, we have been working on the direct contribution of stellate cells to angiogenesis. And we have been looking at both in animal models and also human samples. There is a co-distribution of cells expressing marker of myofibroblasts with cells expressing angiogenic factors. So the same cell that make collagen, they also make angiogenic factor, particularly in the phase of active fibrogenesis when you go from, you start having the septa get into the central lobular vein. But then when you have a established situation of fibrosis like in cirrhotic liver, this ends and angiogenic cytokines are only expressed by endothelial cells. So in this active phase, fibrogenic cells are also pro-angiogenic cells. Okay, a few words about HCC. So if you look at genomics, I made like a very summary. It's more complicated, but just to give you an idea. So if you look at the genes expressed in hepatocellular carcinoma, many times you find that HCC has a chronic wound healing signature. So many growth factors involved in fibrogenesis are relevant in HCC. Also, there are lots of angiogenic growth factor expressed, but also, and this has become more and more clear, there is also lots of gene involved in liver regeneration and also gene related to hepatocyte precursors. So like cancer stem cell can be involved in regeneration. And just to give you an idea, the origin of HCC in animal models is always related to the canal of Herring. So most of the model, like like the salt fiber-like ductal progenitor cells, or some other model. They also highlight the relevance of like a hepatocyte precursor, potentially in the origin of hepatocellular carcinoma. And this work from Tanya Roskam's lab showed that more than 40% of human HCC have hepatocellular precursor features, or in more clear term, like stem cell features, because they express cytokeratin 19 and other markers. And it's I found this paper very interesting, although it's an old paper, because it shows that stellate cells are normally part of the stem cell niche in the liver. So here they have been doing a partial hepatectomy after treating the rats with acetaminophen, which blocks completely the replication of mature hepatocytes. So the liver has to put the stem cell onto the ground to do regeneration. The hepatocyte cannot provide regeneration. So it's a model where you can see stem cell differentiation. And here you see very clearly that there are some hepatocyte precursors proliferating up to terminal hepatocytes, so they stop here. And already while they proliferate, they make the lumen of the sinusoids. And then if you look at who is around this regenerating area, there are stellate cells. So this paper shows also with this other data here that in the process of differentiation of precursor in mature hepatocyte, stellate cell provide support, in many ways, probably just contact support, but also providing probably soluble factor to make sure that this process ends here and is well performed. And so in a situation of chronic tissue damage with a chronic wound healing, you have all this cytokine, growth factor, chemokine, free radical, prostaglandin, all this mess. And this has an effect on the epithelium and also on the stroma, leading to fibrosis. And this leads to cancer. And there are data showing that all this together leads to the differentiation of precursors directly into cancer cells, which may contribute to the origin of some hepatocellular carcinoma. Okay, now let's see what links these non-invasive methods and antifibrotic therapy. It's basically the issue of monitoring fibrosis progression and fibrosis regression if, obviously we have a good, an appropriate therapy. So right now, I'm sure, I think all the clinical people here are totally aware, the liver biopsy is an important, tool. Actually, probably, I think Tillman agrees that, the introduction of liver biopsy is probably the one shot liver biopsy introduced with the Mengele needle is the birth of a pathology, because allowed, to do investigation of what was going on in the liver before the patient was presenting as a terminal patient, yellow or, about to die. And if we look at, how, for which disease liver biopsy is still indicated, we can say that basically liver biopsy is still indicated in all chronic liver disease. Although the yes for hepatitis C and B is smaller than NASH, ASH, and so on, because for NASH, ASH, autoimmune hepatitis PBC, the diagnosis is mainly an histopathological diagnosis. You need fine morphology to say this is a patient with PBC. And for hepatitis C, probably you don't need to do a biopsy. The diagnosis is mostly based on the presence of the virus. And indeed, especially hepatitis C, is a disease which is virus-oriented. It's not oriented even on the patient. I mean, usually you see the doctor looking at a virus in an organism, and basically what everybody cares is to give interferon ribavirin and get rid of the virus. And that day, the patient comes back a human being. But up to that, there is lots of interpretation that hepatitis C is a virus-oriented disease, and particularly for HCV, biopsy is not necessary for diagnosis, and there are several. This is a statement that needs to be actually discussed. several validated non-invasive methods. Okay, now, if we look at how we stage the disease with the Metavir score, for example, which basically it can be called a staging system for dummies because it has only 4 stages. So basically, the pathologist doesn't have much choice. If you put 6, they will make more mistakes. So 4, they make less mistakes. And so you have stage 1 to 4, from expansion of the portal tract to cirrhosis. And then you get to F4, and as I mentioned also before, F4 is an end stage. When you get F4, you will be a cirrhotic patient for the rest of your life, 20 years maybe, okay? And indeed, F4 is not an end stage. We should have F4, F5, F6, F7, but we don't have. And if we look at the endpoints right now in viral hepatitis, as I said before, F2 is an important endpoint because at this point you are mathematically sure that the patient is progressing. It has a fibrosis, which is a dynamic thing, so it's accumulation and degradation, but at the level you have F2, it means that the patient is accumulating matrix, so he's going to become a cirrhotic patient one day. And F4, and this is wrong because basically you say F4, so let's start doing upper GI endoscopy, let's see if the patient has varices, or let's see if he has cellular carcinoma. But this may not happen for 15 years. So, this is a bit too early to think about this, and we need something better. Also, I won't go in all the possible limitations of liver biopsy, but if you, especially for chronic hepatitis C, which is quite dishomogeneous in terms of staging in different parts of the liver, liver biopsy is good for fine morphology, to give some etiological information. It's very good for people like us. We do lots of molecular studies, so we need to have liver samples. But in terms of staging, it gives very little support. I mean, it's not very precise. And indeed, even pathologists like Pierre Bedossa, which is probably one of the top pathologists in Europe, in the world, he made an assessment that even if you have a long biopsy, more than 2.5 centimeters, with a sufficient number of portal tract, liver fibrosis doesn't have a diagnostic accuracy more than 0.9. Basically the idea is 1. So even the gold standard, what is considered the gold standard for non-invasive method, has a 0.9 diagnostic accuracy. And if you read many papers about non-invasive methods, you will have methods with 0.099, which is more than the gold standard, which is impossible. So there is lots of confusion and speculation on what can change, substitute a liver biopsy. Indeed, in the beginning, the non-invasive tools were supposed to change the world and eliminate liver biopsy. Since we don't have very good method yet, so basically what is more modern is that all these non-invasive markers can be used as clinical discriminators. So basically we can divide the patient in patients with likely no fibrosis, likely lots of fibrosis, and what is in between. So overall, we may save, according to different authors, between 50 and 70% of biopsy for the next day. But what is more relevant, and I will address this a little bit, is how we can use the non-invasive method as a prognostic indexes, how it can be used for, for evaluating clinical outcomes. So the serum markers, they divide in direct markers, which are basically related to the fibrogenic process. So they are like circulating procollagen, type 4 collagen, hyaluronic acid, and so on. And these are probably coming from the initiative of the original basic scientists working on fibrosis, highlighting that each one of these molecules is relevant for the fibrogenic process. But the one that became more famous are the so-called indirect markers, which are basically an assembly of the most common abnormalities seen on the clinical charts of a patient with chronic liver disease, like transaminases, platelets, cholesterol, bilirubin, albumin, put together in a mathematical model. And then, a combination between the two. There are several commercially available tests in 2009. I won't comment on this, but consider that probably 5 out of 6 belong to an hepatologist. Okay, and I stop here. Okay, then how I try to make an interpretation of how these serum markers fit into the disease. Okay, so this is the disease. You have the initial phase, which is common to all the diseases, like hepatocellular and biliary damage. Then you have inflammation and matrix degradation, fibrogenesis, and then you have hepatocellular failure, and then you have complication of portal hypertension. So, and then here you have some of the parameters that have been included in the algorithm. Okay, so basically, the aim is to distinguish the disease in 5 stages, okay, from F0 to F4. Okay, let's see how they work. So if fibro test is the most famous, and it goes from here to here. So it takes, transaminases together with cholesterol or aptoglobin. So it takes a long, a very long course of the disease. And then you have some other, they take even more. They go from here to here. They take platelet count and ALT. And then you have some other, like fibrometer or ELF or MP3, which are, direct markers. They investigate more on collagen, which are more restricted. So basically, what is very clear, if a test has one parameter here and one parameter here, will not perform at all in the middle. So basically, these tests are of some utility to distinguish a patient with no liver disease with the cirrhotic patients. And if I ask my professor that now is retired, I will tell, do you need that? You just put your hand on the liver, and you understand you don't need to do a test. And so this remains a gray area. And also there is another gray area after F4, and I mentioned this. So, okay, here you have high pressure. So the overall utility of this test right now is that if you want to distinguish minimal fibrosis with significant fibrosis, you may be able, but not all the tests can differentiate F1, F0 from F2. You cannot make a differentiation F1, F2, F3, F4. You can detect advanced fibrosis and cirrhosis. We don't know if this is helpful for longitudinal studies. There are some studies ongoing now. But overall, as I said before, this test may be useful for reducing the number of biopsies. Okay, then, and I was talking to some of the audience before the seminar, how we should pick a marker to become a good predictor. And, and there are, I think, hundreds of molecules that come up from basic science work in animals, confirmed in humans, that could be reliable. For example, if you take these markers here, which is the long-term prognostic value, like I do a test today, and the test should predict in how many years the patient will have hepatocellular carcinoma or variceal bleeding. So if I take these markers here, they are poor because they are already end-stage markers. So somebody with low platelet count, it won't live many, many years. So these that don't have a long-term utility. The same, ALT or ST or gamma GT, they are poor performance because they are too variable. So some patients will have cirrhosis with ALT normal. And also, they do not reflect the fibrotic evolution. So what I would invest more so far is this other marker here, which are probably always present once you have the chronic wound healing process. And I'm sure everybody in the lab, if you open your lab book, you will have 10 possible candidates to fit in this area. So I think we should work. Somebody is feeling Somebody fell into the hole. So we should work on this area here. Okay, then we have been working on FibroScan that I will not talk about today, although it's very useful. But for people that would like to see basic concept translated into clinical, I was talking before with Christian. It's like buying a new iron board, and to iron your clothes. It's something that came from cheese industry. FibroScan was used in the beginning to assess how hard was camembert. It's true. And then they realized that the liver is the closest to the camembert, and is a solid, soft tissue without many vessels, not like the kidney is full of water, not like the lung is full of air. So basically, they made the FibroScan. They made lots of money, and there is some utility, because if you can take any patient coming with a chronic liver disease, and you do transient elastography, if the patient has less than 6 kilopascal, has no fibrosis. If he has more than 12 kilopascal, has advanced fibrosis, then you still have this limbo here of intermediate value. And so here you have possibly the correspondence to the metavir. And here you don't do biopsy, because it's not yet the time. Here you don't do the biopsy, because it's already cirrhotic. Here you do the biopsy only if you are interested. And possibly you use a serum marker so you can better define. And then in this case, basically the patient is already advanced, so you treat and follow for complication or hepatocellular carcinoma. According to Laurent Castera, to assess the presence of a cirrhotic F4, the FibroScan allows the saving of 90% of the biopsy, more than any other test. But you look here, platelet count, for what it is, it doesn't cost anything. It's very close, 82%. So why you should buy something that costs 80,000 euro? Platelet count doesn't cost anything. Okay, then we get to the end of the talk. How, in terms of therapy, how all this research done in all these years translates into applications. Because I was talking before with the group of Ralph Weiskirchen about, for example, TGF-beta. TGF-beta, it was a target of fibrosis. Everybody has been working on TGF-beta. But then when you, at the moment right now that you have agent able to completely block TGF-beta, you realize that you cannot give them to a patient with a chronic disease, because you will reduce fibrosis, but you will increase inflammation and autoimmunity, and you will induce cancer. So, many times, a good basic product doesn't translate into a clinical product. And here you see, if you go on clinicaltrial.gov, these are some example of, and you put fibrosis as a keyword. This is April 14, it's before the EASL meeting in Vienna. You see there are some trials with antivirals, but in this case, the target is liver fibrosis. So how the antiviral can reduce fibrosis. And they are the first one, because so far they were just directed at reducing the viral load. Then you have angiotensin II receptor antagonist, which is becoming probably the most, although it's something old and already used for many years for hypertension, but still becoming the big hope. There is some work on anticoagulant, so you can give anticoagulant therapy, probably even in a cirrhotic patient, because there was a talk in Bavino 5 that cirrhotic patients don't have a bad coagulation. Actually, they have hypercoagulation, and they have more thrombosis than normal. So you could give anticoagulants. And there are also some trials with diagnostics. So one point relevant here is that calls for the role of angiotensin II receptor antagonist is resistant to apoptosis. At some point, you have an hyperplasia of fibrogenic cells. They become more and more because they don't go into apoptosis. And we have done a paper a few years ago showing that human cells, hepatic stellate cells, as soon as they go undergo activation, they activate BCL2 and they downregulate BAX. And so they set in a situation of resistance to apoptosis. And also in the same study, we look at cirrhotic liver, and there is a very strong co-distribution of fibrogenic cells with BCL2 positive cells. And to our great pleasure, somebody has shown last year that if you look at the number of apoptotic stellate cells in human disease, you have less and less apoptotic cells with the progression of the disease. This is like control, and these are different stages of fibrosis down to like stage 3. And so you have less and less apoptotic cells. So there is a resistance to apoptosis. And what I showed you before, this sharp increase in the fibrogenic progression could be to the fact that there is a reduction of apoptosis that leads to a maximal hyperplasia of cell-making fibrosis. So in this topic, in this area, for many years, although vasoconstrictors like thrombin, vasopressin, angiotensin II are vasoconstrictors, but it has been shown by work of several groups that are also pleiotropic cytokines. They are fibrogenic cytokines. And among these, angiotensin II is the most relevant because there is a lot of evidence that there is activation of a tissue renin-angiotensin system in chronic liver disease. Angiotensin II receptors are overexpressed in hepatic stellate cell, and they promote contraction, collagen synthesis, TGF-beta synthesis and action, and resistance to apoptosis. Particularly, and this is just to show you the first evidence that angiotensin II does anything on stellate cell is a paper that I published in '92, showing that, that angiotensin, this is like kind of, old fart kind of thing, but I'm sorry. You see here, angiotensin II increasing calcium in human hepatic stellate cell, and this was linked to a profibrogenic effect. And this became very relevant because this paper by Fiona Oakley from Derek Mann group published last year shows that stellate cell activation is characterized by the activation of a pathway like AKK beta, phospho-NFKB rel ASR536 that leads to active NFKB, and this is increased cell survival. This is already part of the activation of the cell, but also this leads to the increase in the angiotensin system within the cell, production of angiotensin II, stimulation of AT1 receptor, and further increasing this loop, this signaling loop, then reinforcing the increase in survival. So this gives another reason to treat a patient with angiotensin receptor blocker. And this shows very recent paper from Ramon Bataller group, administration in patient with chronic hepatitis C for 18 months with losartan, and look at genes related to fibrosis or inflammation differentially expressed. You see that most of these genes are markedly downregulated after 18 months of treatment with losartan, and this is genes expressed in liver tissue. Okay, this is people from my lab, and I thank you for your attention.